Welcome to the Business of Podcast. I am your host Deepak from India. Today we have the privilege of welcoming Dr. A. Susana Ramirez as our distinguished guest on the podcast. Dr. Ramirez is an associate professor of public health communication at the University of California, Merced, a social scientist working at the intersection of communication and public health. She investigates how communication can advance social justice and health equity among Latino populations across the equilibration spectrum. Her research program centers on three key areas. First, mapping the public information environment across mass media, social media, and interpersonal networks. Second, assessing how this environment influences health behaviors and outcomes. And third, integrating communication theories with cultural insights to design effective, prevention-oriented health interventions. Dr. Ramirez published studies explore topics such as the development of culturally tailored health messages for bicultural Latina populations, perceptions of cancer risk factors, and patterns of health information seeking. Her current projects are supported by the National Cancer Institute, where she received a K01 Mentor Career Development Award. The Centers for Disease Control and Prevention, the National Institute on Aging, the United Kennedy Shriver National Institute for Child Health and Human Development, and the Hellman Family Faculty Award examine innovative strategies for mobile-based health communication, barriers to healthcare decision-making, and community-based approaches to chronic disease prevention. Before joining UC Merced, Dr. Ramirez completed a cancer prevention fellowship in the National Cancer Institute's Division of Cancer Control and Population Sciences. She holds a PhD in communication from the Annenberg School of Communication at the University of Pennsylvania, a Master of Public Health from Harvard University, and a Bachelor of Arts in Communication from Santa Clara University. In today's conversation, Dr. Susana Ramirez dives into the main ideas from her widely praised book, The Handbook of Language in Public Health and Healthcare. Let's not keep you waiting. Please join me in welcoming Dr. Susana Ramirez to the conversation. Dr. Ramirez, we are deeply honored by your presence and grateful for your time with us today.
Thank you so much for having me. It's my pleasure.
Professor, the handbook frames language as a social determinant of health. How does this shift the way public health professionals should think about health literacy beyond just reading ability in English?
So I want to start by just acknowledging that this book was a collaborative effort with, there were 4 of us editors. And so what I think is really unique about this book is that 4 of us representing really distinct disciplines. We have a physician, we have 2 linguists, but they represent different dimensions of linguistic study. And one of the linguists is also a nurse, a practicing nurse PhD. And then we have me, who represents communication and mass media. And what we realized was that there was a real gap when we talk about language in both public health and clinical healthcare settings, in that it was really limited to thinking about literal translations. And we really wanted to, across the different disciplines that we represent, to think about treating language as a social determinant. And what that means is that we start thinking about health literacy, not just about whether someone can read forms that are written in English or whatever the dominant language is in that particular society, but instead that health literacy is about whether systems are structured to make meaning accessible. We really believe that health literacy is produced in interactions that occur between patients and clinicians and institutions and power. And so when we end up seeing that a system is only working for monolingual speakers of the dominant language, then it becomes easier to understand that limited comprehension isn't the failure of individuals, but a failure of institutional design.
Professor, several chapters discuss language concordance and medical interpreting. What does the evidence say about how interpreter-mediated care compares with true language coordinate care in terms of patient understanding and outcomes?
So I guess I should define what we're talking about and be really clear that the evidence is really strong that professional interpreters improve care relative to having no interpretation. I mean, that's just intuitive. If you have someone who doesn't speak the language of the clinical provider, that's going to be terrible care. It's better to have somebody who's able to do interpretation. But language concordant care consistently performs better. And what I mean by better is that we see that patients ask more questions, they disclose more, which helps physicians better diagnose and come up with treatment plans, and then they show better, stronger understanding and adherence. And as the chapters in the handbook make clear, interpretation then is really a necessary safeguard, but it's not an equivalent substitute for sharing language, sharing understandings of how language is used in clinical encounters, and shared cultural reference points in clinical interaction. Let me just unpack what I mean by that a little bit more. So shared language also means having shared expectations about how communication itself works. So things like how directly do we speak versus kind of indirect comments that are meant to be understood more deeply, how we express disagreement, when it is that questions are invited, and how authority in conversations is negotiated. So one clear example might be when a patient says, "Okay, doctor, I'll try." That may to the patient signal doubt. But in a language discordant interaction, the clinician may hear that the patient agrees with them. And in traditional interpretation, the interpreter is literally translating, "I will try." Whereas when you have language concordant care, that understanding really would be clear. And so what we see is that language concordant care often works better, not just because it's the same language, but because the speaker and the listener are sharing assumptions about how conversational norms are.
Professor, the volume opens with theory, history, and context. How have dominant ideologies about language, such as monolingual norms or colonial language hierarchy, shaped today's healthcare systems and the inequities linguistically diverse patients face?
Um, yeah, so the history and the tradition is really important. And what we are arguing is that modern healthcare systems inherit colonial assumptions that really equate intelligence and compliance and credibility with the languages that have emerged as dominant in particular societies. I can speak mostly to the Americas context. In the United States, what we see is that English is the unmarked norm, and all other languages are really treated as problems to manage. Across much of Latin America, Spanish plays a similar role. And these ideologies really, they shape everything from the forms that you fill out when you're coming into a clinical setting to the training that clinicians receive. And they end up framing linguistic differences as deficiency on the part of the people who don't speak the dominant language, instead of really as a normal feature of plural societies.
Professor, the book highlights language access during public health crisis. What did recent pandemics teach us about reaching multilingual and marginalized communities effectively? And where did public health communication fall short?
Yeah, that's a great question. It's good that we're now starting to think about some silver linings and learnings. The COVID-19 pandemic, especially in the United States, coincided with a moment of heightened attention to racism as a social determinant of health. And it really helped us to understand how fragile language access infrastructures are. What we saw is that where messages about prevention effectively reached the most vulnerable communities, it was because public health partnered with trusted messengers. They used multiple languages that were relevant for their communities early on, and they respected the local communication networks. Where we saw that communication failed, it was because translation came late. It was literal and it was disconnected from people's lived realities. And so the lesson is that thinking about language and linguistic diversity isn't something that you bolt on during emergencies. It needs to be built in as we design preparedness plans. And I just want to stop and say that even though I have 3 degrees in communication, and I think communication is uber important. There is another lesson that's not about communication at all. It is very easy to blame communication for failures that are institutional. You can have the very best communication. You can reach communities via trusted messengers with culturally appropriate, linguistically concordant messaging. But if the resources are not there to support the key messages, if the vaccines are not there, if they are not affordable, if people have no way to buy food unless they leave the house, then you do not have a communication problem, even though it's very tempting to say we tried to communicate with these people and they didn't care. Um, you still have a problem and people are going to get sick. And the solution in these cases isn't better or more communication, it's more resources and better infrastructure. And I really want to emphasize that because it's really easy. And I've literally heard people in positions of power say, we did our best with communication. These people just don't care. They don't want to be healthier. And that's really not the problem. Now, it's also true that insufficient resources and infrastructure can easily become communication problems because if you've gone to the trouble of doing all this good communication and you convinced people to act and they cannot, what you've done is you've risked the credibility of those trusted messengers.
Professor, some contributors write about translanguaging and heritage speakers in clinical encounters. How can recognizing patients' full linguistic repertoires transform clinician training and everyday communication in hospitals and clinics?
This was for me one of the more enlightening sections of the book. I myself am a heritage speaker, so it was really interesting to see how my collaborators and co-editors, who are much more expert than I, really frame this. Just to give a brief response, recognizing the full linguistic repertoires that people in multicultural, multilingual societies bring, or reframes communication from thinking about correctness, whether you are, speaking grammatically correctly, to effectiveness, and getting at that concordance. What we know if we speak multiple languages is that people don't separate languages neatly. They draw on them strategically. And so training physicians and other kinds of clinicians to work with translanguaging rather than trying to police language boundaries like, you can speak in this language in this context, et cetera, that can help to improve rapport and accuracy and trust. And it continues to challenge those deficit views of heritage speakers by recognizing their linguistic competence as complex and adaptive.
Professor, there is a strong emphasis on language education for health professionals. What does the handbook suggest about how language for healthcare purposes should be taught differently from traditional medical Spanish or terminology-focused courses?
Oh gosh. So I would say if listeners take away one message from this conversation, it should be this. It should be that language for healthcare purposes is not about memorizing vocabulary, but it is about authentically valuing language as culture and about how that authentic valuation can shape institutions. So in the handbook, we argue that medical language education should prioritize interaction, it should prioritize ethics, and it should prioritize power over vocabulary learning. And this distinction is really important because traditional medical language courses, in the book, we are offering evidence about Spanish language skills, but those kind of traditional courses produce false confidence in the people who take them. They feel like, I know all the vocabulary I need to know in Spanish, just as I do in English. So now I can go treat patients. But actually, what's needed is training that emphasizes listening, turn taking, uncertainty, and knowing when your partial language skills are really not the best thing, and you should try to draw on a language concordant interaction. So, the bottom line is that language competence is communicative judgment rather than lexical accumulation.
Professor, the handbook brings together applied linguistics, medicine, and public health. What are one or two concrete examples where linguistic research has directly changed the policy, curriculum, or clinical protocols in healthcare settings?
One example is the redesign of language proficiency assessments for clinicians. Like I was talking about, we need to move from just learning vocabulary to thinking about a more interactive model, and that actually has happened, is happening, where they're shifting from written exams to interaction-based evaluations. My collaborator, Dr. Pilar Ortega, has been leading this efforts within the U.S. medical training model. And another is policy change around informed consent, where linguistic research has shown that comprehension depends on the structure of the discourse, not just the accuracy of the translation. And these insights have reshaped the protocols that we use for getting patient consent and also interpreter standards in real life clinical settings.
Professor, mass communication with linguistically diverse populations is one of the 5 core parts of the book. What design principles emerge for campaigns that truly resonate across languages and cultures rather than simply translating slogans?
This is my bread and butter. Effective campaigns, I would say effective communication of any kind, really. You start with meaning. You start with meaning and you start with audience. You do not start with the messages. You do not start with translating ideas or slogans. You start with thinking about what meaning would you like to create, would you like to convey? And you do that by engaging communities in co-design. You do that by attending to metaphor and framing. And then you think about the formats that are the best. You don't just think about the words. Translation assumes that there is some kind of equivalence in phrases or different ways to express things. But when you start with really authentic, deeper designing, then you're assuming that there's going to be difference. So the campaigns that resonate the most are those that respect cultural logics, different media habits that communities have, and the trust relationships that are embedded within different linguistically diverse language communities.
Dr. Ramirez, assessment is a recurring theme for clinician language skills to patient communication needs. What does the handbook recommend for more valid, equitable ways to assess language proficiency and communication competence in healthcare professionals?
In the handbook, we talk about rejecting binary labels like fluent or not fluent. And instead, we recommend task-based, context-specific assessment that evaluates what clinicians can actually do in interaction. And I would add that equity, which is something that we are that really the idea of equity really underpinned the book, that really requires aligning assessment with real communicative demand. So what happens in a clinical encounter? Where are misunderstandings occurring? What are the reasons for those misunderstandings? And trying to figure out how do we do assessment in that context rather than thinking about ideals that are kind of abstract and which end up privileging native speakers and penalize functional multilingualism.
Professor, for health systems, educators, and policymakers listening to this conversation, what are the 3 actionable steps they can take, inspired by the handbook, to embed language appropriate care into their institutions over the next 5 years?
3 actionable steps. Okay. So first, treat language access as core infrastructure, not something that you do for compliance because it's legally mandated and you're getting checked. So it's core infrastructure and it needs to be funded accordingly. And that means investing early. That means recognizing language skills as assets and not remediation. And I think if we think about beyond the specific institution, it also means a cultural shift in how we value multilingualism. And I can speak in the US context, for example, we definitely see children coming into the primary school system and speaking a language other than English and having it be treated as a real deficit. But I think I would argue that if we want good clinical care that values multilingualism, investing early means investing also in a cultural shift that would allow us to see the strengths that those children are bringing in and valuing that and integrating that so that all of our kids can have the benefits of multilingualism. Okay, so the second recommendation is that we reform training and assessment to focus on communication in practice. Again, in real scenarios, what that looks like rather than vocabulary or language as just content for delivering instruction. And then the third, I guess, would be to involve linguistically diverse communities in governance and not just when it's outreach time to them, right? So language equity, I guess, not just language equity, but equity in general, we sustain that through shared authority. And in the context of language equity, it isn't just about translating after the fact, but really ensuring that we have participation and governance from the diverse communities.
Thank you so much, Professor Susana Ramirez, for sharing your time and insight with us today. Your perspective on language, communication, and health has added real depth to this conversation and offered our audience new ways to think about equity in healthcare. The clarity which you connected theory, research, and real-world practice will be invaluable for clinicians, educators, and policymakers who are striving to better serve linguistically diverse communities. Your work not only advances scholarship but also points towards concrete changes that can improve people's lives. On behalf of our listeners and the entire team, thank you once again for this rich and generous discussion. It has been a true privilege to host you, and this conversation will surely stay with our audience long after the episode ends. Thank you once again.
Thank you so much. It was a pleasure to join you.